talk about surgical treatment of AFib, and I think most of you will get to see in the cadaver lab. We're going to show you the techniques of where to put the probe and how to do all that. So I'm going to talk a little more about some of the other parts of it. So the mechanisms sustaining AFib, you have triggers or impulses for AFib, and those can be anywhere in the atrium. They talk about the pulmonary veins being highly concentrated for triggers of AFib, but they can be anywhere in either right or left atrium. You have chaotic signals that come from the macro reentrant circles, and that goes across the AV node, and then you get rapid ventricular response. Jim Cox was the one who developed this operation, and through various iterations was the one who figured out which pathways to use to ablate, and with cut and sew maze, which was the original way of doing it. This was ultimately the Cox Maze 3 operation, which was the one that was really the most successful. So the important parts of the Cox Maze 3 operation, I've worn out my laser, so the important parts are pulmonary vein isolation. Patients with paroxysmal atrial fibrillation very often have triggers that originate in the pulmonary veins. That doesn't mean it's the only place they come from, but the basis of all maze procedures are at least you have to isolate the pulmonary veins from the rest of the atrium, and that can be done individually, isolating the right and left pulmonary veins, but you don't want to individually isolate each pulmonary vein, or you run the risk of getting a scar formation that can cause pulmonary vein stenosis. When you create a scar around the pulmonary veins, you want to be sure that you're actually on the left atrium tissue and not on the pulmonary vein tissue. The cardiologist found that out the hard way, and we found that out the hard way when we had to operate on these patients. So the other part is part of the reason that the maze procedure was so efficacious in controlling stroke was by eliminating the left atrial appendage from the bloodstream, and that can either be ligated or clipped or divided and cut off. One of the problems they had with the early maze procedures is they cut off both atrial appendages, and there's something called atrial natriuretic peptide that is made that comes from the atrial appendages, and you may remember the cut and sew maze patients were just massively volume overloaded. When I started doing the other alternative energy source maze procedures, the cardiologists got up in arms, and they were very terrified that we were bringing back the maze procedure because they remember they could never diurese those patients. They were massively fluid overloaded after surgery, and it was because we cut off both appendages. So the important lesions are circumferentially around the pulmonary veins, the connection to the left atrial appendage, ligating somehow the left atrial appendage, the right atrial lesions we'll talk about, and but the most important lesion besides the pulmonary veins is this lesion that goes from your pulmonary vein lesion around to the mitral annulus. And so this lesion, this area right back here is the mitral isthmus, and if you don't get that in continuity, you run the risk of having left atrial flutter, which is actually worse than atrial fibrillation. It's much harder to control. And so you want to be sure you get this mitral isthmus line. It has to go all the way to the mitral annulus. If you don't get across the mitral annulus, you're going to run the risk of left atrial flutter. The other thing you have to do is make sure you ablate the coronary sinus. So I always pull if I'm doing this as an open operation, I pull the coronary sinus catheter back. I use a cryo probe from the inside, and I do a sandwich lesion with a cryo probe directly on the outside in the exact same place where it went across the inside. So you want to sandwich that coronary sinus between your two endocardial and epicardial lesions. We'll talk about a couple of the different types of energy sources in a second. So the cut and sew maze was the gold standard by which all other ablation procedures are measured. It was very effective. Most studies had anywhere from 95 to 100% freedom from stroke. Some of them carried out to 10 years now. there was a very low mortality. It was durable, but it took a lot of time. It was technically challenging for a universal application. There were several centers that had great results with it, but other places that abandoned it because they weren't used to working back in the back of the left atrium. So Haissaguerre, this is the most overutilized slide I've ever seen. I see this in almost every talk about atrial fibrillation, especially my own. So he did this study where he took 45 patients to the cath lab and he induced atrial fibrillation in all patients that had paroxysmal AFib. And when he looked at where he could induce AFib, the inducible AFib originated in the pulmonary veins in 90% of them. So this was an artificial induction of AFib. This wasn't the actual starting point of the patient's pathologic AFib. But because of this study, and he also found that if he ablated it, if he ablated that area with an RF ablation, he could get rid of the triggers for AFib. So based on this study, everybody thinks that if they isolate the pulmonary veins, they're going to cure everybody of AFib. But that's been a misnomer. So there are substrates and triggers for AFib, and you have to take that into account. But the percutaneous left atrial ablation has taken off, and usually they go through a femoral vein and go across the septum, and they can do these isolation lesions. And I didn't even realize this, but you can see they isolated each pulmonary vein individually at the base of the pulmonary vein, not in the left atrium, but they're doing it in the orifice of the pulmonary vein, which is you know, a good reason to do a lobectomy later on when the pulmonary vein becomes sclerotic. Complications of catheter-based ablation for AFib, cardiac tamponade, pulmonary vein stenosis, esophageal injury, which is rare, but those of us who have seen it don't like it. We don't like the atrioesophageal fistula. I'm sure you've seen that too, and it's not a very good situation. Phrenic nerve injury occurs, thromboembolism, arrhythmias, vascular injuries, and various other complications. This was a clot I took out of a guy about 2 weeks after his left atrial catheter ablation, and it was just stuck to the side wall of the left atrium. Looking at outcomes, the Maze procedure, this is 5-year survival data. If you comparing mitral valve replacement alone versus mitral valve replacement plus Maze versus mitral valve repair plus Maze, and the survival was about the same, but the freedom from AFib was only 6% if you didn't do a Maze procedure, and up to 80% if you did. Freedom from stroke was 79% without the Maze procedure, and 97% if you did it. Some of the energy sources have come and gone. We've used all of these, and the microwave, the laser, the epicardial ultrasound, all of these devices had a 6-month follow-up rate, freedom from AFib of 80 to 90% in all the studies that were done, and suddenly they were pulled off the market, and people were reporting outcomes of 20%. So it's very important to, when you're looking at the literature and when you're trying to figure out the outcomes of these procedures, you have to look at how the patients were followed up. Because if you have a whole bunch of patients in paroxysmal AFib and you do spot check EKGs in your office at 6 months, you're going to get 80% of them that don't have AFib whether you treated them or not. So we have unipolar radiofrequency devices, we have bipolar radiofrequency devices. You're going to see both, you're going to see the bipolar radiofrequency and the unipolar and the cryo procedure in the lab today. This is the cryo probe. It can be done epicardially or endocardially. It works better endocardially. And again, bipolar clamp and the cryo catheter. So the indications for surgical ablation of AFib, symptomatic AFib patients that are undergoing other cardiac procedure is an indication, if you can do it safely. Selected asymptomatic AFib patients undergoing cardiac procedure if it can be done with minimal added risk. Standalone AFib procedure can be considered for symptomatic AFib patients who either prefer a surgical approach or have failed 1 or more attempts at a catheter ablation, or patients not candidates for catheter ablation. And you'll find that the patients being sent to you for a surgical AFib ablation are typically the ones who have failed 3 or 4 previous catheter ablations, or they're miserable in left atrial flutter, or they're the patients that are at the highest risk for not staying free of AFib afterwards. So this study was done several years ago, looking at the incidence of AFib in cardiac surgical patients, and you can see with mitral valve surgery, typically now it's more like 50 or 60%. Bypass patients undergoing bypass surgery have AFib on presentation about 14% of the time. AVR is anywhere from 10 to 20%, and lone AFib obviously is 100%. If you look at all cardiac surgery, about 10% of the patients going to cardiac surgery are in AFib when they get there. So my indication to add an AFib ablation to a cardiac surgical operation is if they have an indicated cardiac operation, the presence of AFib, minimal mattered risk, and the presence of an atrium. So I have no idea which energy source is the best. I know the one that works the best for me is cryo from an endocardial approach. But everybody's trying to make these things less invasive and doing different lesion sets. So the literature is totally heterogeneous. There's a couple of champions who really follow these patients very closely and very rigorously, and they do implantable monitors and long-term Holter monitors and things like that. But most of the reported literature from the EP data and from the surgical data is very heterogeneous. They lump in multiple different lesion sets, epicardial or endocardial or both, intermittent and continuous AFib are lumped together. Duration of AFib is almost never mentioned. Antiarrhythmic therapies is different in every study. They use concomitant procedures and mix them with their standalone procedures. So most of the studies have been very difficult to figure out. But what we do know is that the CoxMaze 3 operation works pretty well. So various different energy sources. This is cryo from the inside. You can put the patient on pump, open the left atrium with an empty, cold heart. You can, that's a Hank Williams song. You can cryo the entire Maze 3 lesion set on the inside of the heart. And with cryo on a bloodless field from an endocardial approach, the transmurality is probably the best of any of the other devices. Bipolar can give you good results as well, but it's very hard to get to some of the places you need to get to, like across the mitral annulus. Those of you who were in the anatomy lab yesterday know that right near this mitral annulus is the circumflex artery, and it can run along the where you're trying to ablate. So this study over here showed an epicardial approach where they took a unipolar radiofrequency probe, went around the pulmonary veins, made a connecting lesion, went across the base of the atrial appendage, and then they went towards the coronary sinus, but not across it. And so right here, this pathway right there is going to be left atrial flutter, and that patient's going to be miserable. So with radiofrequency, a combination of bipolar radiofrequency and cryo, you can actually do all the lesions of the Maze 3, now called a Maze 4 operation, if you do it with an alternate energy source. This just shows the unipolar RF. Remember that pulmonary vein isolation alone is not a CoxMaze operation. This just shows the access to get around the pulmonary veins. We use a red rubber tube to get around without traumatizing the pulmonary veins. This can be done off pump. It's a little easier if you're on pump with the heart decompressed. But once you get the clamp across, you want to make sure that you're on the left atrium and not on the pulmonary veins, so you don't get pulmonary vein stenosis. And you can see you can put that radiofrequency clamp across the, I've opened up the fat pad there so you don't have a big thick wad of insulating fat. But you want to make sure you're on the left atrium and not on the pulmonary veins. So the results of bipolar radiofrequency ablation in 130 patients, if they did the full CoxMaze 4, all the lesions of the CoxMaze 4, they had 90% freedom from AFib. Left atrial ablation alone, all the lesions was 86%, but pulmonary vein isolation alone was only 59% freedom from AFib. So that's my important take-home message. You can get all of the lesions of the CoxMaze 4 operation and ligate the left atrial appendage through a little mini thoracotomy if you use cryo and you're on pump. And that just shows the cryo lesions. See that in the lab. Remember that from an endocardial, from an epicardial application, the left atrial blood inhibits the heating of the radiofrequency or inhibits the cooling of the cryo. So you're going to have a hard time getting full thickness. You also have the fat that insulates. From an endocardial approach, you can get endothelial damage if you've got blood flowing through. That's a risk of thromboembolism. So endocardial approach, consider doing it on pump. And we talked about the standalone AFib. You can do a hybrid approach, which includes catheter ablation and a less invasive surgical ablation, inside out, outside in. Remember that when we're using these probes, we can actually make connecting lesions and see where we're making our lesions. In the cath lab, you've got the heart beating and you're hitting it with a probe like this, and they think they're making a linear lesion, but it's really if you have ever seen this after surgery, after a catheter ablation, you open the left atrium, it looks like a series of dots all over the place. Always ligate the left atrial appendage in any patient who comes to the OR and AFib. You can use ligate it from the inside if you do a double running suture line. You don't want to do a purse string or a figure of 8 because those are wrought with recanalizations. But if you do a secure running double suture line, you can close it securely, or you can use an etcher clip from the outside. So I think I talked about all of my summaries and conclusions already.